Thank you so much, and good evening to everyone. I'm not sure where everyone's located, but I assume it's quite late for some people. It's certainly a little bit late for me. I'm in Melbourne tonight, so it's 11 p.m. for us. So if you catch me yawning, you'll have to forgive me, but that's okay. I'm going to present two tools that we implement across Asia Pacific. Talk a little bit about the background to the Tupaia project, and hopefully leave plenty of time at the end for any questions. I'll try and do some live demonstrations as well. But as I say, overall, hopefully a fairly informal presentation that gives you a good picture of what it is we do. And we always start with this slide. Tupaia was a Pacific Islander. It was a real person. He joined Captain Cook's crew in 1769 as Captain Cook came through the Pacific, through Tahiti and Polynesia and on to Australia, with all their modern tools. And the project is named in his honor. So this is what we call the Tupaia ecosystem, and this is a really, really high level look at our tech stack, or at our architecture, and how Tupaia fits into that. We implement a range of softwares at Beyond Essential Systems, and Tupaia is just one of them. It's certainly our the most widely used logistics management information system in the world for low and middle income settings. They're just to form part of Tupaia's as a standalone implementation. And Tupaia MediTrack is our data collection app. I'll show you Tupaia MediTrack very quickly tonight. It's very similar to a lot of the data collection apps you would have seen from other organizations around the world. A lot of them are very similar, and we're very aware of that, but we have a data collection app that we use mainly for cross-sectional surveying of health facilities and health staff. We've recently received funding to build out what we call Tamanu Lab in an integration with Senate, which is a free and open source laboratory information management system from Europe, which we're really excited about implementing, and that integration is being done with Fleming Fund support in Papua New Guinea. So that is what we call it, if you like, our Tupaia ecosystem, and at the center of it all is Tupaia. So Tupaia is a data aggregation, analysis, and visual and visualizes it for specific user groups in customized views. So we use it for disaster response, for supply chain strengthening, for disease surveillance, for tracking the quality of health services across health facilities. Prior to that, UNFPA, Gates Foundation. We've done a little bit of work with WHO and a number of partner countries. Obviously, free and open source, and we hope to always be able to do that. Tupaia started at the start of 2017, so we've been around now for just over 3 years, and our funding is in place for the next 3 years as well through the Indo-Pacific Centre for Health Security. So this kind of, I guess, covers some ground that we've already talked about. But the primary aim of Tupaia, if you like, is to aggregate data in real time by pulling it from multiple sources via APIs. Now, where data doesn't exist, we can go out and into Tupaia MediTrack, which, as I say, is our data collection software, but our preference is for existing data sources. And what we point out with Tupaia all the time is that we don't come in and replace software. We complement existing software. So we are not a replacement for DHIS2. We're certainly not a replacement for MSupply. And in fact, with both those softwares, we implement them. So we're very clear that we're not replacing any software. We sit in the middle of those pieces of software and pull data from multiple sources. Now, an obvious question that we get asked quite a lot is, well, why wouldn't you just use DHIS2? DHIS2 has the ability to integrate using an API and has the ability to visualize data in customized views. And that's true. And in fact, we do use DHIS2. DHIS2 is the basis of our aggregation server that pulls a lot of our data sources together. Why is DHIS2 not enough on its own? One reason is we are able to support multiple data hierarchies, which DHIS2 can't. And that's not a criticism of DHIS2, it's just not how it's set up. And that allows us, for example, to map schools within a country, but also health facilities, weather systems, whatever the case may be, add in data layers and present them in different hierarchies to different users, or overlap the hierarchies if we ever need to. So, for example, we have an environmental health project in Fiji where the hierarchy is water catchments, river systems, and communities, whereas your health projects in Fiji might be your administrative boundaries, health facilities, villages. So it's that's one thing. It's also, as you'll see tonight, hopefully, very mapping-led. So we're very, very based around our mapping-led visualizations. There's not a lot of configuration that you need to do, or there's no configuration that you need to do once Tupaia is set up. If you need to interrogate your data, if you need to really interrogate your data, if you need to produce your annual reports, or if you're working in the health information unit and really need to dig into data in deeper ways, you would use DHIS2 or a bespoke software in your setting. But that's not what Tupaia is for. It's for, as I say, the visualization step and that pulling different data sources together. And to do that, we have a team of software developers managing those integrations, because as we all know, integrations using APIs can be quite unstable depending on what happens with the architecture of the databases that are connected together. And what happens frequently is that the integrations break and you need to get in software developers anyway to fix it. And in most of the countries that we work, that is just not possible within the country. There is just not that software development capacity within the Ministry of Health to maintain them. We kind of do it for them, if that makes sense. Well, there you go. That kind of goes over a lot of what I said. And as I said, we rely very heavily on our technical partners for implementation and that data for decision making step. We do provide some technical support particularly in supply chain, but predominantly we rely on technical partners, whether they're research institutes, universities, partner countries, vertical programs, or donors, to be out there implementing Tupaia and making the change happen from the data. This is probably less relevant for tonight, but we host a lot of data that's increasing fairly rapidly all the time, and we host data across a whole range of things, from live fridge temperatures in our immunisation module to annual assessments of disaster preparedness capacity at health facilities. There's a huge range of data that we might host. So tonight I want to talk about some of the COVID-19 support tools that we have been building, and predominantly they sit in these 5 areas. And what I haven't talked about yet is Tamanu. So Tamanu is a patient-level electronic medical record that I'll talk about tonight and do a quick demonstration on. We've also been building out COVID-19 tools within Tamanu, but they've been relatively easy because Tamanu is built to be across all disease areas. It's not a specific registry or anything like that, and we can go through that tonight. But within Tupaia, the ability to do facility assessments, the ability to do national health system readiness assessments, the ability to do disease surveillance for COVID-19, we've all built out in the last month or so. We do have basic contact tracing tools within Tupaia, and they are used in 2 countries in the Pacific. We don't push them too much. Our contact tracing tools are relatively simple. They're not what you might call sophisticated for really large populations. They work very, very well in the smaller contexts that we use them in the Pacific. You are able to create index cases. You are able to build out contact cases from those index cases, survey the contacts, and link them back to the index case, all within Tupaia MediTrack, and do things like map your suspected and confirmed cases, map your contacts, and all that sort of thing. But we wouldn't describe them as sophisticated contact tracing tools. And in some settings, it would be probably preferential for us to use contact tracing tools as a data source rather than to use Tupaia for them. Not to say that we don't want people using them. Of course, if people would like to look at them more, we're more than happy to show you, but I won't be demonstrating them tonight. So the easiest thing for us to do, and I'll see how we go. I've done a number of screenshots, which I'll look at the live website. If I can just pull that up. Let me pull up Tupaia. I hope you're all following along. I hope someone interrupts me if you can't still see my screen, but I assume you can. This is the landing page for Tupaia. So these are some of the projects that we work with. We have a few smaller projects that aren't on our landing page. And I'm going to just really quickly step you through some of the general tools that we use, and then some of the COVID-19 tools that we've applied. So first and foremost, we'll jump to Australia, where we've built out a number of COVID-19 tools as a bit of an example project. Australia is not a focus country for us. It's not obviously a low and middle income country, but it is a rich source of data, and we do occasionally build tools within Australia to demonstrate them to other countries or to test certain features, and COVID's been a good example of that. So for example, you're looking at a map here of Australia, and we can map total confirmed cases by state using a heat map. So that's what we call a shaded polygon, showing a heat map of cases in Australia. And you can see that our outbreak in Australia has been predominantly focused on the East Coast, particularly in New South Wales and Victoria. So when we talk about our map overlays, that's what appears here. Now, dashboards appear over on the right. And you can look at things like total confirmed cases by state. If we concertina that back. These are all automated. So we have linked these to a number of data sources in Australia that are collecting data each day and updating these dashboard elements. One of the tools here, this is cumulative cases in Australia. You can see that we've been very, very fortunate in Australia. Our outbreak is already leveling off. But with all the tools in Tupaia, you can update, well, not with all of them, sorry, but with some of our longitudinal charts, you can update the dates at the top, adjust them to whatever you would like. So say you're interested in, let's say the middle of February, you want to take it back to then, and that will update. And once you're happy with the view that you're looking at, you can download that either as a PDF or as an image file. So these are all automated epi curves. You can see this is the daily count of cases in Australia. We're getting very, very close to elimination, but not quite. Total tests per capita. Again, this is quite an interesting chart to look at by narrowing the date field that you're looking at. And as I say, as much as possible in the countries that we're working in, this is automated. So we pull from existing data sources so that people aren't having to construct these on a daily basis. This is some interesting ones we've been working on recently, confirmed cases versus deaths in Australia. And you can see we've recently had a tail off in our cases. We've had a few deaths in the last few days, but we would expect them to really tail off into next week. Now, one of the points that we make is that it's mapping led, and what we mean by that is that these dashboards over on the right will automatically update based on the view that you are looking at. So if we zoom into New South Wales, we can now see LGAs, local government areas, sitting underneath the state level. And these charts over on the right, these dashboard elements have automatically updated. So what we're looking at is now just New South Wales. New confirmed cases by day just in New South Wales. We can zoom down to Victoria, which is the state that I'm in tonight, and you can see that that dashboard is updated on the right, which is quite handy. So if we zoom out again and we come and look at some of our other COVID-specific assessments in Tonga, for those who don't know, Tonga is a Polynesian country in the Pacific. It's a relatively small country. The trick that I just did then, by the way, in Tupaia, you can toggle between a satellite view and a vector map view. It auto detects your bandwidth so that it will default to a satellite view, which looks more interesting. But if your bandwidth is low, it will toggle you to a vector map view that we pull from OpenStreetMaps. And you can manually do that by clicking on this little button down here. If we really zoom in and look at the main island of Tonga, Tongatapu, we can pull up, some map overlays here. So, for example, they've been doing facility assessments the last couple of weeks in Tonga. So whether they have water for hand washing, whether they have soap for hand washing, and you can see these pins on the map updating. Now, I apologize. I have been told that sometimes when we're doing presentations, the colors don't stand out very well. They stand out for me, but I'll toggle back and forth to see if one view is better than the other. You can see here that in Mua, the soap for hand washing is out of stock. You can see whether they've got hand sanitizer, gloves, face masks, and of course all of this updates in real time as this data is collected through Tupaia MediTrack. Now, one of the things that we use in Tonga, though, is we have implemented MSupply and MSupply Mobile, and that's their stock management software. So that for some of these questions, they are coming through MSupply, and paracetamol would be an example of that. So if paracetamol is in stock at the facility, we are pulling that data in real time from MSupply, which is quite cool, really. You can also then look at whether they have ICU beds and whether they have isolation beds, and this demonstrates really quite clearly the problem that the Pacific faces. Is not good. Most of the facilities in Tonga don't have ICU beds. There's very few in the entire country, one there in Mua. Now, these are basic map overlays, and one of the reasons that it's not particularly interesting to show our COVID tools in Tonga at the moment is that they don't have any cases. Well, they certainly don't have any confirmed cases. We do AeHIN, MSupply. They use Tupaia as their data aggregation platform, and so when you go to an individual facility, you can see a huge number of dashboards for them. Not all users can see all these dashboards. So, for example, if you are working on the health promotion team or say the reproductive health team, you can see these dashboards on things like contraceptive prevalence rates or reproductive health visits, but they're not generally available to the public. The reason I come to these dashboards relevant when we're looking at big data sets in these matrix views. Now, Tonga actually provides what is called the package of essential health services. So this is called different things in different countries. Some people call this the role delineation policy. Some people may call it supportive supervisory tours, or a tool to support supportive supervisory tours. The thing that I wanted to show you is these matrix views, which allows you to do what we call traffic light assessments of facilities. These are the facilities that we're assessing in Tonga, and these are the services that they are supposed to be providing. And again, you could apply them to a COVID-19 facility assessment. If you wanted to see, for example, diagnostic services, if it's grey, the facility is not supposed to provide that service, so that's not something that we worry about. But if it's orange or red, there's an action plan that sits behind that, that you are able to view for each facility and then aggregate up into some other dashboard elements I'll show you in a second. Now, these can be downloaded as raw data, and you can see where this is particularly useful if you want to really dig into the data, or as a PDF to insert into a report. Those action plans compile up into not that. So if you look at the areas that Tonga should be working on, you can see that the bang for the buck is in staff training and equipment. That's what most of the action plans say are the two main areas that that are needed to turn those areas green, whereas spending on infrastructure is maybe going to be less efficient. Not to focus too much on Tonga's package of essential health services, but to give an example of the sort of tools that are available for facility assessments in Tupaia and how they can be really quickly adapted to COVID-19. To come out and look at really quickly just at another country that we work with, which has more facilities than Tonga. This is Solomon Islands, which has somewhere in the order of 320 facilities. To look at a few of the other things that we do. So this is a heat map of medicines available. Where the facility is using M-Supply, we pull the data in real time from M-Supply. Where they're not, it's based on the last time that they were surveyed using Tupaia MediTrack. And that gives you a really good heat map of medicines availability in the country as a percentage to help you identify where bottlenecks might be occurring or whatever the case may be. You can also look at a bubble map, so looking at inpatient beds. So the bubble map of ICU beds was not very interesting in Tonga because there really are no ICU beds, or there's one or two at some facilities. Now this is a bubble map of all inpatient beds in Solomon Islands, where the bubble obviously shows the size of the beds. And the other thing that we can do is multi-metric map overlay. So for example, if you wanted to see the current number of usable beds, you can present a coloured bubble map, or the normal number of inpatient beds. So the size of the circle indicates how many beds that they would usually have, and the colour of the circle indicates something else about them. So this is sample data from a country called Demoland that we have been using for the last few years to demonstrate and train and test our data. We note that that DHIS2 is now using a similar idea, which we're taking as a compliment, but it's a really great tool. So we use Demoland to show off some of our functionality, and this is one of them, a coloured bubble map. Using the legend below, you can turn that. Now we're only looking at facilities that have been completely affected, for example, by a recent disaster, and you can go and use that to zoom into their dashboard. So that's a really skimming look at Tupaia. As I say, we use Tupaia for a whole range of other things, from a pilot project that we did last year looking at fridge temperatures. I can very, very quickly show you that because I'm conscious of time, but we're quite proud of the way that works. So if you come and look at one of these facilities and look at their daily fridge temperatures, again, you can set this to a period of time that you're more interested in. So that started in November 2019 and submit that, and that adjusts. Now those are live daily maximum and minimum fridge temperatures from the Maternal Child Health Clinic at George Pompidou in Vanuatu, and that obviously allows the National Cold Chain Coordinator to see those fridge temperatures from a Bluetooth sensor that's installed in the fridges without having to travel to the facilities. And that's also integrated with M-Supply so that you can see vaccine stock on hand figures in real time, which is quite a cool and nifty trick. So coming back to the presentation, as I say, that's a really, really quick overview of Tupaia. And we could talk about it for quite a while. We've got 5.7 million data points in there now, so there's quite a lot to look at. But I wanted to spend a few minutes also talking about Tamanu. So Tamanu, as I said, is a patient-level electronic medical record for mobile and desktop. And the history of Tamanu is a lot shorter. We set out about 2.5 years ago to find an electronic medical record that met the needs of the Pacific. We set 5 principles that we wanted that software to achieve. It had to be sync enabled. That means not a web service that only worked online or that sort of cached data in order to share it. It needed to be completely offline first and sync whenever the internet was available, modeled very much on the M-Supply model, so that you can have a local database at every single site across desktop and mobile, work for weeks at a time if needs be, and sync the data to a central server whenever the internet becomes available. Had to be completely free and open source, you know, not a subscription model or anything like that. Had to be desktop and mobile enabled out of the box. So rather than having complicated integrations with kind of a central database, make sure that it was desktop and mobile enabled, off the shelf. Obviously data fully encrypted at rest and in transit. And it had to be interoperable with, you know, coding systems, you know, be it ICD-10 or integrations with DHIS2, M-Supply, and other standard softwares, either via REST APIs or HL7. And we couldn't find one. So we looked for a software that met those 5 principles, which we think are absolutely necessary for software in the Pacific. Now, this may not be the case everywhere. The internet may be completely reliable in all places, never go down and always fast. Some countries may have no need for open source software and can afford to pay ongoing licensing fees and for customizations. But in the Pacific, we felt strongly that you needed shelf-ready software that met these 5 principles. And we are very much open to people correcting us on this, but we were fairly confident that it didn't exist. So we've spent the last 2 years building out Tamanu and piloting it in a couple of sites. We believe have a couple of small national implementations coming up, although COVID has really messed around with our plans there. But we're really proud of it and really keen for people to see it being used. So this is some screenshots from the mobile version, and it's a birth to death system. So it includes birth registration, death registration, an immunisation register that integrates with M-Supply so that you can track the stock that each individual patient was given. It can obviously track outpatients and inpatients, and in the mobile version can track programs, so data collection around vertical programs. It's configurable so that you don't have to hard code it in every time a program wants to collect data. It has basic dashboards in the mobile version, but you export data for more, for deeper analysis, and you can see patient histories. These are screenshots from the desktop version. I wanted to very quickly demonstrate that. Just check the time. Still got a little bit of time. This is the desktop version of Tamanu. I've probably got time at least to show you this. So this is how you would manage patients in an inpatient facility, generally speaking. Actually, am I looking at the? Oh, I am. Where to start? Let's triage this patient. So this is Todd Frank. He's presented to the emergency department. These are all obviously fake patients. It goes without saying. We've built it based on a 3-level triage system that is starting to be rolled out across the Pacific with the support of WHO. Not Tamanu, I should say. This 3 triage system. There's some explanatory information there if you click on the information link. And let's say this person has cardiac chest pain. You can record vitals. So let's say, oh gosh, you're testing me here. Let's say the heart rate's 70, the respiratory rate's 15, the temperature is 37, oxygen sats are 97, and let's say that they are alert. So you can record that. Not in this database, but you can also track surveillance here at the emergency triage level. I'll say that I was the triage clinician tonight. and you can submit that triage. And what it has is a waiting list whiteboard for patients in the emergency department. So you can see here a waiting list that prioritises based firstly on their triage score and then on their wait time. And so that a clinician just needs to come along and see who's at the top of the list. Jeremy Tacky, who's been waiting for 59 minutes and has difficulty breathing. You can then bring up that patient at the diagnosis. And this at the moment is using ICD-10, including we learned to type, the COVID-19 codes that have just been released in the last few weeks. And let's say that that is a confirmed diagnosis. I mean, obviously, you're not going to get a confirmed diagnosis in the emergency department for COVID-19, but let's live in a perfect world. Result then later. On discharge, it also pushes their medication information into M supply so that it can be dispensed, and it's M supply that handles the stock management. So those are the tools around Tamanu. With both Tamanu and Tupaia, what we would, I guess, suggest is if people want to see them more, if they want more demonstration, if they think that they would be appropriate for them, please get in touch with us and we can do a full demonstration of them. As I say, they are completely free and open source, and we're always looking for implementing partners. We really genuinely are not in this for the profit or the glory, and if there's a really appropriate implementation partner, we're happy for them to take our software into new environments and to implement it with our blessing and with our support. And we think in some settings that this ecosystem, as we call it, is appropriate. And of course, in other settings, it won't be appropriate, and that's fine as well. So I should also add, really finally, with Tamanu, it does handle patient identification, so that you can create unique identifiers in Tamanu and use that as the source of truth for patient registration, or it can link via an API to a third-party source of truth for patient identification, whether you have an existing database of patients or a government system or whatever the case may be. We can pull our patients in from there. This is now back on our spreadsheet. The final thing to say is that one of the key uses for Tupaia is to use an emergency operations center. As you can imagine, for data aggregation software, one of the primary use cases is emergency operations center. Whilst we are using Tupaia MediTrack, which is our data collection tool, is completely offline and sync enabled, so you can go out and collect data using the app, of course. Do as many facilities as you like, and implement sync the data when the internet becomes available. Tamanu works completely offline across desktop and mobile. Tupaia.org, which is where we were looking at the visualizations before, here does not work offline at the moment. So at the moment, to see these visualizations, you do need to be online, and you can set up a local version of the database on physical servers in your country, or you can run it on a cloud architecture, but you do need to be online and connected to that central server for it to work, which is the biggest weakness in the system. And we now have funding through DFAT and in a partnership with Population Services International to create a sandboxed version of Tupaia.org. So this could sit on any server, including mobile servers, and sync with that central server every 10 minutes. So that, for example, if you're doing a health cluster meeting, you could be doing all your data visualizations and your presentations without any fear that the internet was going to drop and you're going to lose them. At this time of night, for me, that is probably enough talking, and I'm happy now to go up and answer any questions. Let me just work my way back through these slides and settle on this architecture, which hopefully helps to paint the picture a little bit better. And I think, yeah, the timing is probably pretty good. If anyone has any questions or comments or criticisms, not too harsh, I'm happy to talk to them now.
Thank you, Dr. Michael. The first question is, how does Tupaia compare with DHIS2, and what makes it same and what makes it different?
Yeah, as I said at the start, we like DHIS2 and we use DHIS2 and implement DHIS2. And in fact, in the tech stack for Tupaia, we have DHIS2 sitting at the heart of it as our aggregation server. So a lot of data comes into a DHIS2 instance that sits within Tupaia. And when I say that, the bottom left-hand box in the screen that you're looking at here is actually made up of a fairly complicated tech stack that has an aggregation server, which has an app server, an aggregation server, a configuration server, and then a front end, and then we pull mapping layers from external sources. So it's quite a complicated tech stack that sort of sits under the hood. But the aggregation server is DHIS2. So when people ask us, why didn't you just use DHIS2? We answer, well, we did. DHIS2 sits at the heart of it, but it's a highly, highly customized version of DHIS2, particularly with customized APIs. And we're now using a Postgres database sitting alongside it, which allows us to do, as I said, multiple data hierarchies. DHIS2 is great software, but it's also bound by certain rules. And we have kind of done customizations to get around some of those rules as best we can. And the other thing is, I mean, this is not a slight at DHIS2 by any means, but it's our visualizations are pretty cutting edge. We use a number of different tools that DHIS2 doesn't use out of the box for our visualizations, and we're able to use things like recharts, leaflet, mapbox, OpenStreetMaps, and layer them all together, as well as a few other tricks that we use, so that the user experience is pretty amazing. But as I say, it has a DHIS2 instance sitting at the heart of it. The other point to make is that for the countries that we work in predominantly, a lot of the smaller and really low resourced countries in the region, maintaining DHIS2 integrations is actually not that easy. Even if you want to integrate mSupply with DHIS2, which a lot of countries have done successfully, Laos being one, you need software developers maintaining those integrations. It's not just set and forget. And we all know that as changes are made to the databases on both sides, it can break those integrations. So it's efficient to have a software that sits in the middle and can maintain those integrations without constant support by each of the individual countries. We have a team of software developers in Melbourne that maintain those connections into Tupaia, and then countries can kind of use them for free and take advantage of that efficiency.
Thank you, Dr. Michael. Our next question is, how fast can Tupaia be set up for a country of 100 million people?
Well, that is an excellent question, and it very much depends on the functionality that you want to use. If you want to use out-of-the-box functionality, the tools that we have are very, very scalable. So if you look at the tools that we have implemented in Australia, say you wanted to do heat maps of confirmed COVID cases, automated epi charts, do some basic facility assessments and track some basic commodities, as in tools that we already use, it would only take, I don't want to say immediately, but a few days to get it set up. If you had the data, if you were able to give us the data, assuming that the data was all in shape and didn't need to be cleaned, our tools are all highly scalable, so that, whether we're presenting, 1,000 facilities or we're presenting 13,000 facilities, shouldn't really make a difference. We wouldn't anticipate any performance issues around that. What would be tricky is implementing Tamanu for 100 million people. We have designed Tamanu to work, for countries, I don't want to say countries, we've designed it to work in settings of 10 million people or up to 10 million people. For Tamanu to work across 100 million people would require some customizations. Essentially, we would be aggregating a number of servers together, and it would take, I suspect, several months. But implementing Tamanu, which is a patient-level medical record system, is complicated anyway. There's a lot of requirements gathering and configuration, obviously, that has to go into that. So a few months is probably not that out of the question. But to implement Tupaia in a country of 100 million people, using out-of-the-box tools that we already have, you're looking at a week or two.
All right, thank you, Doctor. The next question is, what is the minimum number of IT staff needed to manage Tupaia for 100 million citizens?
Well, I mean, as I say, again, it depends on the functionality and how many sort of data aggregations that you have or integrations you have. But the short answer is zero. The software can be maintained by our team in Melbourne, and we are supported through the Australian government to provide that service to countries in the Indo-Pacific. So we, if you like, the Department of Foreign Affairs and Trade in Australia, the Indo-Pacific Centre for Health Security, kind of gives us a pool of grant funding, and countries are then able to come to us and say, oh, this is what we want to do, and then we can say, usually we say yes, and it is supported through that grant. So the short answer is zero. Obviously, if there is capacity within the government, most of the countries that we work with have zero IT staff. They certainly have zero software developers. But if there is capacity within local governments, we're very, very keen to work with them and upskill people so that they can manage those systems in the long term. Particularly, say, for example, if it was an emergency operations centre, we would be looking to build a local base of support for that, so that it's not constantly having to come back to us, and that in 4 and 5 and 10 years time, it's sustainable at a local level. But certainly for the next 3 years, you could get it up and running with no local staff.
All right. The next question is, how long does it take to train a field person on Tupaia?
Training a field person in data collection on Tupaia Meditrack is quite easy. On Tupaia Meditrack, we usually just spend a 2-hour session with them, and we can get data collectors. That's if they have a health background. So long as they understand the data that they're collecting, learning how to use the app to go and collect data is very simple, particularly in countries that have higher digital literacy. But we work in countries in the Pacific that have some of the lowest digital literacy in the world, and we're still able to train people up in using those tools quite quickly. When I say they have a health background, if you're having people going in and assessing, whether the staff require training, whether they have proper isolation beds, isolation capacity, whether they have proper infection prevention and control procedures, obviously they need some base knowledge in that. The data that they're collecting that's a piece of string as to whether they're trained up in that. But say you're sending a pharmacy officer out to look at commodity information, we would train them up in the tools in a couple of hours.
Thank you, Dr. Michael. The next one is, are you familiar with Dewar? How does Tupaia compare with it?
I don't think so. Dewar is familiar, but I don't think I've ever come across it. So I have to beg ignorance on that, unfortunately, which is embarrassing. But I'll be Googling it tomorrow morning to find out more about it.
All right, thank you, Doctor. The next one is, how compliant is Tupaia with the COVID-19 framework of WHO?
I guess I'm not super certain I understand the question about compliance. We have been using WHO tools at every level for the tools that we've been building out. So, for example, our facility assessment tool we've used for COVID-19 in Tonga and Samoa is based on the WHO facility assessment and tool. We also brought in some questions from the Centers for Disease Control tool. Our National Health Readiness survey was based on a WHO tool, and our case definitions for our suspected patients surveillance surveys have also been based on the WHO case definitions. So it's obviously been shifting, and different countries have been adapting it. So as much as possible, we've been using WHO tools. In Tamanu, we've also incorporated ICD-10 coding within the diagnosis tool, but I don't know how else the question means, whether there's other compliance.
All right, thank you, Doctor. Our next question is, how much should a Ministry of Health need to invest to set up and maintain its own Tupaia for 100 million citizens?
Look, as I say, it's very much how long is a piece of string. So I hate to put figures around it. The project that we're doing, we've got a project coming up in a Southeast Asian country around an emergency operations centre, and the additional input being put in by the donors on that project and remember it's a 2-year project that will be quite comprehensive, is 100,000 Australian dollars, so about 60,000 US dollars. But we are also working in countries where the countries don't pay anything and have never paid anything. So it really varies enormously. As I say, the out-of-the-box tools, everything that I showed tonight, and to get this up and running, as you've seen tonight, is free. For the next 3 years, it's supported by the Australian government. So the size of the country really wouldn't matter. Where the investment needs to come on the countryside is on the data for decision making, and that answer would be the more the better. We can only provide the tools really for a country of 100 million people. What you do with those tools is really up to the ministry or the Department of Health in each of the countries, and there's really no limit. The more the better. But there would be no investment needed to us, if that makes sense.
Thank you, Dr. Michael. The next question is, how can Tupaia interface with other systems like a hospital's lab information system?
Sure. So, we've just actually, as I say, received funding to integrate with Senate, which is a European laboratory information system. We're integrating with that via REST APIs. Senate, in turn, can connect with some hardware either via REST APIs or HL7. Tamanu itself is HL7 compliant, but there's no need for us to use HL7 directly in that case, because we are integrating with Senate, and so it's all done through there. We're customizing that and skinning Senate, and the project is called Tamanu Lab. We would then pull data out of that to display in Tupaia. We're actually building those tools as an antimicrobial resistance hub, so looking at AMR data, but obviously it'd be interesting to see if we can turn them to COVID-19 quite quickly.
Thank you, Dr. Michael. I think this is the last question. So how can you separate anonymous data from named patient data?
In Tupaia, I think I'm understanding this question correctly. So in Tupaia, we don't display any named patient data. So Tupaia is de-identified aggregated data because Tupaia is not encrypted. It's encrypted in transit, the data, but it's not encrypted at rest. And so we wouldn't describe it as a secure software. It's highly secure, it's password protected. We've got really granular permission systems. We have a firewall that sits on the server, but we don't display identifiable patient data in Tupaia. So as in tupaia.org, the maps and everything that you saw. Now in Tamanu, which is the patient level electronic medical records system, that data is obviously all confidential, and it's encrypted on the disk. So when we need to aggregate and report on it, we run those reports. I don't know how much detail you want. Certain fields within all of our data tables are encrypted. They are the patient fields and anything that could identify the patient. We are able to run most of our reports without needing those encrypted fields, and if we do need to, we can run that report to kind of pre-configure them. So say, for example, you want a list of all the patients that have had COVID-19 and you want a list of their names in Tamanu, that takes some grunt on the server because it needs to unencrypt all of the patient names. So we kind of set it up as a pre-configured report that then runs in the background before you call it up. As I say, I could talk for a little bit longer about that, but that's basically how we do it.
Maybe before we wrap up this call, we can call on Dr. Alvin Marcelo.
Thank you, Michael. We learned a lot about Tupaia. Thank you for having this again for AeHIN. We are recording this call because a lot of countries in Asia are now looking for possible solutions for their COVID-19 information systems. So I hope we can tap you again when the Ministries of Health, at least in the Philippines, have more specific questions, Michael. Thank you very much.
Terrific, and thank you. As I say, we can be contacted through details on each of our websites, or my email is michael@beyondessential.com.au.
Thank you so much, everyone.